Welcome back to the Deep Dive. This is where we take your questions, your notes, your sources, and we really just dive in deep. We pull out the crucial info you need to get up to speed fast.
Yeah, cutting through all the noise, we're sort of navigating this information landscape together, trying to spot the key landmarks so you get the whole picture without, getting totally bogged down in the details.
Exactly. And today, well, we have quite a journey laid out for us. Based on the materials you sent over, we are taking a really deep dive into the pathology of bones, cartilage, joints, and soft tissues.
And these sources, they really give a comprehensive overview, starting with the basic structure, how these tissues develop, which is fascinating in itself.
Right.
And then moving into common diseases, infections, and the whole range of tumors, both benign and malignant.
So our mission today is to really explore all of this thoroughly. We want to make sure you don't just learn the names, but you understand the why and the how behind these conditions. We're really getting you to that place of deep, elite level understanding.
Turning dense info into clear insights. That's the goal. Let's get started.
Okay, so, yeah, to understand what goes wrong, we absolutely need to start with how things work when they're healthy. Let's kick off with bone. What's its fundamental role in the adult skeleton?
Well, it's foundational, both literally and figuratively. The skeleton gives us crucial mechanical support, protects our vital organs.
Oh, the ones, yeah.
Right. But it also acts as this dynamic reservoir for minerals, especially calcium and phosphorus, keeping that balance across the whole body. And super important, it's where we make our blood cells hematopoiesis.
It's incredibly active tissue then, not just scaffolding. And it's built from this matrix. What's actually in the bone matrix?
It's basically two main parts. There's the organic bit called osteoid, making up about 35%, and then the mineral part, the inorganic stuff, that's the other 65%.
Okay, what's the osteoid made of?
Mostly type-I collagen. That's what gives bone its flexibility, its ability to resist pulling forces. There are also other proteins and sugars in there, like osteopontin, which bone cells make. It helps guide mineralization, and we can actually measure it as a marker of bone-building activity.
And the minerals, that's the hard part, right?
Exactly. That's primarily hydroxyapatitite. It's a crystal form of calcium phosphate. This is what gives bone its rigidity, its hardness. And it's this huge storehouse, holds like 99% of the body's calcium and a big chunk of its phosphorus.
So you've got this composite material, but I understand the way the collagen is organized makes a big difference. Woven versus lamellar bone.
Huge difference, yeah. Think of woven bone like scaffolding thrown up in a hurry. The collagen fibers are disorganized, they run in all directions, it gets made quickly, like when a fetus is growing or when a fracture is healing initially.
But not as strong?
Not nearly as strong, no. Lamellar bone, that's the mature, organized stuff. The collagen fibers are laid down in these neat parallel layers, or lamellae, much higher structural integrity. In a healthy adult, pretty much all bone should be lamellar. Finding woven bone elsewhere usually signals a problem, like a tumor or Paget disease.
And within a typical long bone, you have that dense outer layer and the spongy inside.
That's right. The cortex is the dense, compact outer shell providing most of the strength. Inside is the medulla, which has this network of fine bony struts called trabeculae. That's the spongy or cancellous bone, and it's filled with bone marrow, the blood-forming tissue.
Got it. Now let's talk about the cells, the living parts. Who are the main players here?
Okay, you've got the builders, the osteoblasts. They sit on the bone surface, and their job is to synthesize the osteoid matrix, that organic part, and then control how the minerals get deposited onto it.
The construction crew.
Basically, yeah. Their activity is tightly controlled by hormones and local signals. Once they've done their job, they can either become quiescent, sort of resting bone lining cells, or they get embedded within the matrix they just made.
And when they get trapped, they change roles, they become osteocytes.
Precisely. Osteocytes are the mature bone cells, fully encased in the mineralized matrix. They live in little spaces called lacunae, and they have these long, thin processes reaching out through tiny channels, canaliculi, connecting them to each other and the surface.
So they're not just passive residents.
Oh, not at all. They're like the sensory network. They monitor the local environment, help control calcium and phosphate levels nearby, and crucially, they detect mechanical forces like weight-bearing stress or muscle pull.
And they translate that force into signals.
Yes, that's mechanotransduction. They sense the strain and send signals to the osteoblasts and osteoclasts on the surface, influencing remodeling. It's quite sophisticated.
So sensing stress, coordinating the builders and the demolishers.
Osteoclasts, yeah. They're the demolition team.
And they come from a different lineage, from blood cells.
That's right. They developed from circulating monocytes. which are a type of white blood cell, part of the macrophage family. They fuse together to become large, multinucleated cells specialized for breaking down bone.
How do they actually do that?
They attach firmly to the bone surface, create a sealed-off zone underneath them, the resorption pit. Then they pump acid into that space to dissolve the minerals, and they release enzymes, like proteases, to break down the organic matrix, the collagen. They basically excavate the bone.
It's an incredible balance.
Yeah.
Okay, how does a bone actually form and grow in the first place, especially the long bones?
The main process is called endochondral ossification. It starts early in development with mesenchymal cells forming a cartilage model, a template shaped like the future bone that's the amylogen.
So cartilage first, then bone.
Exactly. This cartilage model is gradually replaced by bone. First, a primary ossification center appears in the middle of the shaft, laying down the cortical bone. Later, secondary ossification centers form at the ends of the bone, the epiphyses.
And connecting these centers are the growth plates.
Yes, the physes, or growth plates. These are critical layers of cartilage sandwiched between the epiphysis and the diaphysis, the shaft. This is where longitudinal growth occurs.
How does that work within the plate?
The cartilage cells, chondrocytes, in the growth plate undergo this highly ordered sequence. They proliferate, increasing in number, then they hypertrophy, getting much larger, then they undergo programmed cell death, apoptosis. As they die, the matrix around them mineralizes.
And then the bone builders move in.
Right. Blood vessels invade this calcified cartilage, bringing in osteoblasts, which start depositing osteoid, new bone matrix, onto that calcified scaffold. This calcified cartilage acts as a temporary framework, which gets remodeled into the first bony trabeculae, the primary spongiosa.
So this whole process pushes the ends of the bone apart, making it longer.
Precisely. It drives longitudinal growth until the growth plates eventually close in late adolescence.
But you mentioned not all bones use cartilage first, flat bones.
Correct. Some bones, like the flat bones of the skull or the clavicle, form through intramembranous ossification. Here, mesenchymal cells differentiate directly into osteoblasts, which just start laying down bone matrix without a pre-existing cartilage template.
And bones can also grow wider, thicker.
That's appositional growth. New bone is deposited directly onto existing bone surfaces under the periosteum, making the bone increase in diameter.
Okay, these processes seem incredibly complex. What's controlling all this, the development and the ongoing metabolism?
It's a really intricate interplay of systemic factors, like hormones circulating in the blood and local factors acting within the bone environment. Systemically, things like growth hormone from the pituitary and thyroid hormone are major regulators, especially of growth plate activity.
And locally, within the growth plate itself.
There's crosstalk. For example, Indian hedgehog protein produced by chondrocytes getting ready to hypertrophy signals to cells in the surrounding periosteum. Parathyroid hormone-related protein, PTHRP, produced near the ends of the bone, acts to keep chondrocytes proliferating, preventing premature maturation.
What about the master switches, the genes that decide cell fate?
Transcription factors are absolutely key. SOX9 is essential for making chondrocyte precursors. RUNX2 is critical for driving cells towards becoming fully mature chondrocytes and also osteoblasts. Then you have signaling pathways like the Wnt pathway.
Wnt signaling comes up a lot in development.
It does. Wnt proteins bind to receptors like LRP5 and LRP6 on osteoblasts, activating intracellular signaling, particularly involving potonin, which promotes bone formation. Other signaling molecules like fibroblast growth factors, or FGFs, have complex roles, sometimes inhibiting chondrocyte proliferation. And bone morphogenic proteins, BMPs, part of the TGF family, have diverse effects on chondrocytes and osteoblasts. It's a busy signaling network.
Okay, that covers development. But once the skeleton is mature, it's not static, right?
Yeah.
You mentioned remodeling.
Absolutely not static. The adult skeleton is constantly being turned over. We replace roughly 10% of our bone mass each year through this process called remodeling.
Why do we do that?
Several reasons. It repairs micro damage that accumulates from daily wear and tear. It allows the bone to adapt its shape and structure in response to mechanical loads, to use or lose it, basically. And it plays a role in maintaining mineral homeostasis, releasing calcium and phosphate into the blood when needed.
And this happens at specific spots.
Yes, in discrete units called basic multicellular units, or BMUs. You can think of these as temporary construction sites on the bone surface. It's a tightly coupled sequence of events.
Demolition first, then rebuilding.
Exactly. First, osteoclasts arrive, attach, and resorb a packet of old bone. Then they disappear, and osteoblasts move in, proliferate, and lay down new bone matrix in the cavity that was just created. Finally, this new matrix gets mineralized.
How is this coupling orchestrated?
Yeah.
What ensures the builders follow the demolishers?
Signaling pathways are crucial. One of the most important involves three key molecules: rank, rankle, and OPG.
Okay, break that down. Rank, rankle, OPG.
Okay. Rank is a receptor found on the surface of osteoclast precursors. Rankle is the ligand, the key that fits the rank lock. Rankle is produced mainly by osteoblasts and stromal cells in the marrow. When rankle binds to rank, it gives the signal for the precursor to differentiate into a mature, active osteoclast and also promotes its survival.
So rankle activates the bone destroyers. What does OPG do?
OPG, which stands for osteoprotogerin, is also secreted by osteoblasts. It acts as a decoy receptor. It looks like rank, so it binds to rankle and prevents rankle from binding to the actual rank receptor on the osteoclast precursors.
Ah, so it blocks the activation signal.
Exactly. OPG inhibits osteoclast formation and bone resorption. So the balance between rankle and OPG is a critical determinant of bone resorption versus formation.
So the ratio of rankle to OPG basically sets the thermostat for bone breakdown.
That's a great way to put it. A high rankle to OPG ratio favors resorption. A low ratio favors formation or maintenance. There are other factors too, like MCSF, another signal from osteoblasts that's essential for generating osteoclasts in the first place. And WNT proteins, acting on osteoblasts, promote bone formation partly by stimulating OPG production.
And you mentioned sclerostin before from the osteocytes.
Right. Sclerostin is made by those osteocytes embedded within the bone matrix. It acts as an inhibitor of the WNT signaling pathway in osteoblasts, so it essentially puts the brakes on bone formation. This feedback from within the bone itself is another layer of control.
And how does the actual breakdown of bones signal the builders to come in, the coupling mechanism?
That's partly intrinsic to the process. When osteoclasts resorb the matrix, they release various factors that were trapped within it, things like fragments of collagen, but also stored growth factors like TGF-beta and BMPs. These released molecules can act as signals to attract osteoblast precursors to the site and stimulate them to start laying down new bone.
It really is a beautifully orchestrated system. And all this contributes to achieving our peak bone mass. When does that happen?
Usually in early adulthood, maybe late 20s or early 30s, after the skeleton stops growing in length. The maximum amount of bone we achieve, our peak bone mass, is really important for later fracture risk.
What determines how high that peak is?
Genetics play a major role. Variations in genes controlling things like the vitamin D receptor, components of the WNT pathway like LRP5 and LRP6, the rankle-OPG system, even immune-related genes all contribute. But lifestyle factors are huge too. Nutrition, especially adequate calcium and vitamin D intake during growth, physical activity, hormonal status, it's multifactorial.
And then after we hit that peak, it's generally downhill, unfortunately.
For most people, yes. Starting sometime in the fourth decade, the balance shifts slightly and bone resorption begins to slowly outpace formation. This leads to a gradual, age-related loss of bone mass throughout the rest of life.
Okay, that's a fantastic foundation on healthy bone. Now let's pivot to what happens when those initial developmental blueprints go wrong. You mentioned a key distinction: dysostosis versus dysplasia.
Yes, it's an important distinction. Dysostosis refers to a problem in the formation of a specific bone or group of bones. It's often due to localized issues during development, like problems with how mesenchymal cells migrate or condense. Think of it like a localized defect. Maybe a bone is missing aplasia, you have an extra one, supernumerary. Or bones are fused together improperly, like syndactyly fused fingers, or craniosynostosis, fused skull sutures.
So a localized glitch in the blueprint.
Kind of, yeah. Often linked to mutations in specific genes, especially transcription factors controlling early patterning, like homeobox genes. Dysplasia, on the other hand, is a more global disorganization of bone and cartilage development throughout the entire skeleton.
A system-wide problem with the building code.
That's a good analogy. Dysplasias result from mutations in genes that control the fundamental processes of skeletal development, growth, and remodeling. And importantly, unlike the term dysplasia used for epithelial tissues, skeletal dysplasia does not mean it's precancerous.
Okay. And there are many of these conditions.
Hundreds, actually. Over 350 recognized, though most are individually rare. The classification is constantly evolving as we understand the genetic basis better. It can be complex because sometimes different mutations in the same gene cause very different clinical pictures, or mutations in different genes can surprisingly lead to similar appearances.
Let's look at some examples based on the categories in our sources. First, defects in nuclear proteins or transcription factors like messing with the core instructions.
Right. These affect how mesenchymal cells organize and differentiate. For instance, mutations in the HOXD13 gene, a homeobox gene important for limb patterning, can cause brachydactyly, abnormally short fingers or toes. Another classic example is cleidocranial dysplasia. This is caused by losing function of the RUNX2 gene. RUNX2 is crucial for osteoblast differentiation. People with this condition often have wide open fontanelles in the skull, delayed closure of sutures, extrawarmian bones in the skull, underdeveloped or absent collarbones, clavicles, dental abnormalities, and short stature.
So RUNX2 is essential for making proper bone cells.
Very much so. Other examples listed involve genes like SOX9, linked to campomelic dysplasia, TVX5, Holt arm syndrome, heart and limb defects, LMX1B, nail patella syndrome, and PX3, Waardenburg syndrome, hearing loss and pigmentation issues along with skeletal features.
Next category, defects in hormones or signal transduction pathways. These affect how cells multiply and mature, right? Achondroplasia is the big one here.
Achondroplasia is the most common form of skeletal dysplasia causing dwarfism. It's almost always caused by a specific type of mutation, a gain-of-function mutation in the FGFR3 gene. This gene codes for a receptor for fibroblast growth factors.
Gain of function means it's overactive.
Exactly. Normally, FGFR3 signaling acts as a brake on chondrocyte proliferation in the growth plate. In achondroplasia, the mutated receptor is constantly on, even without the FGF signal, so it excessively inhibits cartilage growth, particularly in the growth plates of long bones.
Leading to the characteristic short limbs.
Yes, disproportionately short limbs, especially the proximal parts, upper arms, thighs, are the hallmark. The trunk length is relatively normal, and the head is often large with a prominent forehead and depressed nasal bridge. Importantly, intelligence and lifespan are typically normal. About 90% of cases are due to new mutations, often linked to advanced paternal age.
How does that compare with phenophoric dysplasia, which is also linked to FGFR3?
Phenotoric dysplasia involves different but also activating mutations in FGFR3 that cause an even greater increase in the receptor's inhibitory signaling. The effect on bone growth is much more severe. Very severe micromelia, extremely short limbs, a severely underdeveloped chest cavity which leads to respiratory failure and other abnormalities. It's the most common lethal form of dwarfism, usually fatal at or shortly after birth. The sources also list other conditions in this category, like hypochondroplasia, a milder FGFR3-related dwarfism, and some forms of osteoporosis or osteoporosis linked to mutations in LRP5 or ARNKL, affecting Wnt or osteoclast signaling, respectively.
Okay, moving to defects in extracellular structural proteins. This sounds like problems with the actual building materials, like collagen. Osteogenesis imperfecta, or OI, is the classic example.
Yes, OI, often called brittle bone disease. It's the most common inherited connective tissue disorder. It mainly affects bone, but also impacts other tissues that are rich in type I collagen, like joints, eyes, ears, skin, and teeth.
What goes wrong with the collagen?
It's usually caused by mutations in the genes for the two chains, alpha-1 and alpha-2, that make up type I collagen. These mutations can lead to decreased production of normal collagen, or, more often, the production of abnormal collagen molecules that don't assemble properly.
And the abnormal protein can interfere with the normal ones.
Exactly. Many mutations, particularly those substituting another amino acid for glycine in the crucial triple helix structure, cause misfolding. This abnormal protein can then disrupt the formation of the entire collagen fibril. Even incorporating normal chains, it acts in a dominant negative fashion. That's why most forms are autosomal dominant.
And the fundamental problem is too little functional bone.
Yes, the underlying issue is a deficiency in normal type I collagen, leading to insufficient bone mass, osteopenia, and bone that is inherently fragile and prone to fracture.
What are the other classic signs? Blue sclerae.
Right. The sclerae, the whites of the eyes, can appear blue or grayish because they are thin due to the collagen defect, allowing the pigment of the underlying choroid layer to show through. Hearing loss is also common due to abnormalities in the small bones of the middle ear or nerve issues. And dental problems, specifically defects in dentin, dentinogenesis imperfecta, occur because dentin also relies on type I collagen.
And OI exists on a spectrum of severity.
Definitely. It ranges widely. Type 1 is generally mild, with fractures primarily in childhood that often decrease after puberty, and a normal lifespan. Type 2 is at the other extreme uniformly lethal in utero or shortly after birth due to extreme fragility and multiple intrauterine fractures. The severity often correlates with the type and location of the collagen gene mutation. The sources also mention that defects in other collagen types, like type 2 collagen COL2A1 mutations, cause different skeletal dysplasias affecting cartilage primarily.
We also touched on mucopolysaccharidosis, again, problems degrading complex sugars. How does that fit here?
Well, while they are primarily lysosomal storage diseases, they have significant skeletal manifestations. The problem is a deficiency in enzymes needed to break down glycosaminoglycans, mucopolysaccharides. These substances accumulate within lysosomes, particularly in chondrocytes.
And that messes up cartilage function.
Yes, the accumulation disrupts chondrocyte function, can lead to their death, and interferes with the integrity of the cartilage matrix. Since cartilage is so crucial for endochondral bone formation and growth, this leads to skeletal abnormalities like short stature, chest deformities, and malformed bones.
Okay. Another metabolic pathway defect mentioned is osteoporosis, where bone resorption fails.
Right. Osteoporosis, sometimes called marble bone disease, is a group of rare genetic disorders where osteoclasts either don't develop properly or can't function correctly. The net result is reduced bone resorption.
So bone density increases, makes them like stone.
It does increase dramatically. The bones become very dense, sclerotic, hence the name stone bone. However, this bone isn't normal.
It's brittle. That seems counterintuitive.
It does, but the problem is that the bone isn't being remodeled properly. You end up with dense but poorly organized bone, often persistent woven bone, or primary spongiosa that hasn't been replaced by stronger lamellar bone. So despite the density, it's structurally unsound and prone to fracture, like chalk.
Why can't the osteoclast do their job? What are the underlying defects?
Most mutations interfere with the osteoclast's ability to create the acidic environment needed in the resorption pit to dissolve the mineral. For example, mutations in a gene for a chloride channel, CLCN7, are common in a milder autosomal dominant form. Mutations in AR-NKL can cause a severe infantile form by affecting osteoclast development. Defects in carbonic anhydrase 2, an enzyme needed for acid production, are another cause.
What does the bone actually look like pathologically?
Because resorption is impaired, the medullary cavity fails to form properly or gets filled in with dense bone. The ends of long bones can become club-shaped or flared, the classic Erlenmeyer flask deformity seen on X-rays. The increased bone mass can narrow the foramina, the holes in the skull where nerves pass, leading to cranial nerve compression.
And the lack of marrow space is a big problem.
Huge. The primary spongiosa, the earliest trabecular bone formed during development, persists and fills the space where the hematopoietic marrow should be. This leads to anemia, low white blood cell counts, leukopenia, increasing infection risk, and low platelets. The body tries to compensate with blood formation in the liver and spleen, extramedullary hematopoiesis, causing them to enlarge.
So fractures, nerve problems, and blood cell issues. Clinical outcomes vary.
Yes. The severe autosomal recessive infantile form is often evident at birth and can be fatal early due to infections, bleeding, or neurological complications like blindness or deafness from nerve compression. Milder autosomal dominant forms might only be discovered in adulthood incidentally on X-ray or due to recurrent fractures.
Is there any effective treatment?
Remarkably, yes. Because osteoclasts originate from hematopoietic stem cells, hematopoietic stem cell transplantation, bone marrow transplant, can be curative, especially for the severe infantile forms. The donor stem cells give rise to normal, functional osteoclasts that can start remodeling the bone properly. It was a pioneering example of treating a genetic bone disease this way.
Okay, fascinating. Let's shift gears now from these developmental disorders to metabolic bone diseases problems that affect ongoing bone mass and mineralization, usually kicking in later in life.
Right. Here we're looking at conditions that disrupt the normal balance of bone turnover and mineral metabolism after skeletal maturity has been reached. The most common issues relate to bone mass, osteopenia, and osteoporosis.
Osteoporosis is the one everyone's heard of, right? Loss of bone mass.
Exactly. Technically, osteopenia just means decreased bone mass. Osteoporosis is defined as a more severe loss, typically quantified by bone mineral density measurements falling more than 2.5 standard deviations below the average peak bone mass of young adults. This significantly increases the risk of fractures.
And it can be localized or system-wide.
Yes. Localized osteoporosis might happen in a limb that's immobilized, for example, but when we talk about it as a metabolic disease, we usually mean generalized osteoporosis affecting the whole skeleton, though perhaps to different degrees in different areas.
What's the difference between primary and secondary osteoporosis?
Primary osteoporosis is the most common type, where there isn't one single identifiable underlying cause. This includes age-related bone loss, senile osteoporosis, and the bone loss that occurs after menopause, postmenopausal osteoporosis. Secondary osteoporosis is when the bone loss is a consequence of another medical condition or medication, things like endocrine disorders, hyperthyroidism, Cushing's, certain cancers, gastrointestinal malabsorption, or long-term use of corticosteroids.
And it's a huge public health issue.
Absolutely. It affects millions, leads to over 1 million fractures per year in the U.S. alone, huge healthcare costs, and significant morbidity and mortality, especially from hip fractures.
So what drives the bone loss in the common primary forms? How does it happen?
Well, it really starts with achieving the best possible peak bone mass in early adulthood. Genetics, nutrition, activity level during those formative years set the stage. Then, after reaching that peak, everyone experiences a gradual age-related decline.
Why does age cause bone loss?
Several factors contribute. Osteoprogenitor cells, the stem cells for osteoblasts, become less responsive and don't multiply as well. Osteoblasts themselves become less active, producing less matrix. Growth factors stored in the bone matrix might become less effective. And often, physical activity decreases with age, reducing the mechanical stimulus for bone formation.
Okay, that's the slow age-related decline. What about postmenopausal osteoporosis? That seems more abrupt.
It is. The decline in estrogen levels after menopause is the key driver. Estrogen normally has a protective effect on bone, partly by restraining osteoclast activity. When estrogen drops, this restraint is lifted.
How does estrogen loss boost osteoclasts?
It leads to increased production of certain inflammatory cytokines like IL-1, IL-6, and TNF by immune cells and bone marrow cells. These cytokines, in turn, stimulate osteoblasts and stromal cells to produce more ANKL and less OPG.
Tipping the RANKL-PG ratio towards resorption.
Precisely. More on-NKL means more osteoclast activation, differentiation, and survival. This leads to a state of high bone turnover, but with resorption significantly outweighing formation. The bone loss is particularly rapid in the first decade after menopause and disproportionately affects cancellous spongy bone, which has a higher surface area for remodeling.
So age contributes, but estrogen loss dramatically accelerates it in women.
That's right. And underlying genetic factors related to RANKL-OPG, estrogen receptors, vitamin D receptors, etc., still influence individual susceptibility and the rate of loss. Inadequate calcium and vitamin D intake can worsen both senile and postmenopausal osteoporosis.
Pathologically, what does osteoporotic bone actually look like under the microscope?
The crucial point is that the bone tissue itself is histologically normal in structure and mineralization. There's just less of it. The quantity is reduced.
So it's not bad bone, just not enough bone.
Exactly. In cancellous bone, like in the vertebral bodies, the trabeculae become thinner. Some get completely perforated and disconnected, losing the normal interconnected architecture. This severely weakens the structure. In cortical bone, the outer shell thins, primarily from the inside, endosteal resorption, and the Haversian canals within the cortex widen.
Like a honeycomb structure where the walls are thinning and breaking down.
That's a good visual. The overall structural integrity is compromised.
And the clinical consequences are mainly fractures. Spine, hip, wrist.
Yes. Vertebral compression fractures are very common, leading to back pain, loss of height, and spinal deformities like kyphosis, dowager's hump, or scoliosis. Fractures of the femoral neck, hip, pelvis, and wrist are also characteristic. Hip fractures are particularly devastating, often leading to prolonged immobility, complications like pneumonia or blood clots, and a significantly increased risk of death in the following year.
And it's often silent until a fracture occurs.
Unfortunately, yes. Significant bone loss, maybe 30–40%, has to occur before it's easily visible on a standard X-ray. That's why specialized bone density scans, like DXA scans, are needed for earlier diagnosis and risk assessment.
Okay. Now, contrasting with osteoporosis, you mentioned rickets and osteomalacia involve problems with mineralization.
Correct. In these conditions, the osteoblasts produce the osteoid matrix okay, but the subsequent step, the deposition of calcium phosphate mineral, hydroxyapatite, onto that matrix is impaired. So you have an accumulation of unmineralized or undermineralized bone matrix.
And rickets is the childhood version.
Yes. Rickets occurs in children whose growth plates are still open. The lack of mineralization at the growth plates leads to widening and disorganization, and the poorly mineralized growing bones are soft and prone to bowing and deformities under weight-bearing stress. Osteomalacia is the adult counterpart, occurring after the growth plates have closed. Here, the defect affects the bone formed during remodeling, making the adult skeleton weak, painful, and susceptible to fractures.
And the most common cause for both is related to vitamin D.
Yes, by far. Vitamin D deficiency from inadequate sunlight exposure, poor diet or malabsorption, or problems with its metabolism or action are the leading causes, because vitamin D is essential for absorbing calcium and phosphate from the gut and for normal bone mineralization.
Another condition affecting bone metabolism is hyperparathyroidism, too much parathyroid hormone, PTH. How does that impact bone?
PTH's main job is to maintain blood calcium levels. One way it does this is by stimulating bone resorption to release calcium into the blood. It acts indirectly on osteoclasts.
How does it do that indirectly?
PTH binds to receptors on osteoblasts, signaling them to increase their expression of ARNKL and decrease OPG. This again shifts the balance heavily towards osteoclast activation and bone breakdown. So chronically elevated PTH leads to increased bone resorption.
And this can be primary from the parathyroid glands themselves or secondary.
Right. Primary hyperparathyroidism is usually due to a tumor or hyperplasia of the parathyroid glands, causing them to autonomously secrete excess PTH. Secondary hyperparathyroidism is a compensatory response to conditions that cause low blood calcium, most commonly chronic kidney disease.
Why does kidney disease cause secondary hyperparathyroidism?
Several reasons converge in chronic renal failure. The failing kidneys can't excrete phosphate efficiently, so phosphate levels rise in the blood. High phosphate indirectly lowers calcium. Also, the damaged kidneys are less able to convert vitamin D into its active form, which further reduces calcium absorption. Both low calcium and high phosphate strongly stimulate the parathyroid glands to produce more PTH. Metabolic acidosis from kidney failure can also contribute to bone loss.
What does severe untreated hyperparathyroidism do to the bones? What's the classic pathology?
In severe symptomatic primary hyperparathyroidism, you see several characteristic changes. There's generalized bone loss, essentially osteoporosis, but it particularly affects the cortical bone, like in the fingers, phalanges. You can get brown tumors. These aren't true cancers, but localized accumulations of osteoclasts, reactive giant cells, and fibrous tissue within areas of bone destroyed by excessive resorption, often with hemorrhage giving them a brown color.
And osteitis fibrosa cystica.
That's the term for the combination of increased bone cell activity, both resorption and formation, though resorption dominates, fibrosis developing in the marrow spaces around the trabeculae, and the formation of these cystic brown tumors. It represents the severe classic skeletal manifestation. Microscopically, you might see osteoclasts literally tunneling through the bone trabeculae, creating dissecting osteitis.
Is it as severe in secondary hyperparathyroidism?
Usually the skeletal changes are present, but tend to be less florid or severe than in uncontrolled primary hyperparathyroidism. But significant bone loss and changes still occur. Importantly, controlling the underlying cause, like treating the parathyroid adenoma or managing the kidney disease, can lead to regression of these bony changes.
Which brings us to renal osteodystrophy, the broader term for bone issues in kidney failure.
Exactly. Renal osteodystrophy encompasses the whole spectrum of skeletal abnormalities seen in patients with chronic kidney disease, especially those on dialysis. It's a mix of features.
Like what?
You can see components of osteopenia, osteoporosis, osteomalacia due to vitamin D issues and acidosis, the effects of secondary hyperparathyroidism that we just discussed, and growth retardation in children. Histologically, the bone can show different patterns. High turnover bone disease driven by PTH, low turnover or aplastic bone disease where bone formation is suppressed, sometimes related to aluminum toxicity from dialysis in the past or just adynamic bone disease, or mixed patterns.
So kidney failure hits bone metabolism from multiple angles.
Absolutely. Tubular dysfunction leads to acidosis, dissolving mineral. Impaired phosphate excretion drives up PTH. Reduced vitamin D activation lowers calcium. And newer research highlights disruption of other signaling axes involving molecules like FGF23 from osteocytes and BMP7 from kidney tubules that normally coordinate kidney and bone function. It's a really complex interplay leading to diverse skeletal problems.
Okay, we've covered density, mineralization, and metabolic balance. Now, let's tackle Paget disease of bone. This sounds like chaotic, disorganized remodeling.
That's a very good description. Paget disease, also called osteotis deformans, is a localized disorder, or sometimes multifocal, characterized by excessive and disordered bone remodeling. You get phases of frenzied osteoclast activity, followed by frantic but ineffective osteoblast activity, leading to bone that is enlarged, structurally unsound, and deformed.
You mentioned phases: lytic, mixed, sclerotic.
Yes. It typically starts with an intense osteolytic phase, dominated by large, overactive osteoclasts resorbing bone. This is followed by a mixed osteoblastic phase, where both resorption and formation are happening at a high rate. Finally, it can enter a late, burned-out osteosclerotic phase where osteoblast activity predominates, leaving behind dense, enlarged, but disorganized bone.
Who gets Paget disease? It's more common later in life.
Yes, usually diagnosed in late adulthood, becoming increasingly common with age. There's also a striking geographic variation. It's relatively common in people of Anglo-Saxon descent, UK, US, Australia, New Zealand, but rare in Scandinavia, Asia, and Africa. The prevalence seems to be decreasing in some high prevalence areas recently, which is interesting.
What's thought to cause it? Still uncertain.
The exact cause remains unclear, but it seems to involve a combination of genetic susceptibility and possibly environmental factors. Mutations in the SQSTM1 gene, which is involved in pathways regulating osteoclast function, specifically NF-EB signaling, are found in a significant proportion of familial and some sporadic cases. There's also been long-standing speculation about a viral trigger, perhaps a slow virus infection like measles, affecting osteoclast precursors in genetically predisposed individuals, but definitive proof is lacking.
What's the absolute hallmark feature you see under the microscope?
The pathognomonic feature, especially in the later sclerotic phase, is the mosaic pattern of lamellar bone. Because the bone is remodeled so rapidly and haphazardly, you get these prominent, irregular cement lines joining oddly shaped packets of lamellar bone together. It looks like a jigsaw puzzle or crazy paving under the microscope.
And during the active phases?
You see evidence of intense activity. In the lytic guard phase, waves of resorption with large numbers of unusually large osteoclasts, sometimes with dozens or even 100 nuclei. In the mixed phase, you see both these hyperactive osteoclasts and plump-active osteoblasts laying down woven bone initially, which then gets remodeled into that mosaic lamellar pattern. The marrow spaces often get filled with loose, vascular connective tissue.
And all this chaotic activity leads to bone that's bigger but weaker.
Exactly. The affected bones become enlarged, thickened, but also porous and structurally unstable. This leads to the clinical problems.
What are the common symptoms?
It's highly variable. Many people are asymptomatic, and it's found incidentally on X-ray or due to elevated alkaline phosphatase on blood tests. When symptoms occur, bone pain is common, often due to microfractures or nerve compression from bone overgrowth. Enlargement of the skull can cause headaches, hearing loss, or nerve compression. Long bones in the legs can bow under weight-bearing stress, leading to deformities and secondary osteoarthritis in adjacent joints.
And fractures are a risk.
Yes, the abnormal bone is prone to pathological fractures, often described as chalk stick fractures because they tend to break transversely, like snapping a piece of chalk. Vertebral compression fractures can also occur. Another feature is increased blood flow through the highly vascular pagetic bone, which can make the overlying skin feel warm and, in severe widespread disease, can even act like an arteriovenous shunt, potentially leading to high-output heart failure.
And the most feared complication, though rare:
malignant transformation into a sarcoma, usually osteosarcoma or fibrosarcoma. This occurs in less than 1% of all patients, but maybe 5–10% of those with severe polyostotic disease. It typically arises within a pagetic lesion and has a very poor prognosis.
How is it usually diagnosed and treated?
Diagnosis relies on the characteristic radiographic appearance: enlarged bone, thickened cortex, coarse trabeculae, elytic or sclerotic areas, and the markedly elevated serum alkaline phosphatase, indicating high bone turnover, with normal calcium and phosphate levels. Treatment, usually with bisphosphonates or calcitonin, aims to reduce the excessive bone turnover, relieve pain, and prevent complications. Most cases are not life-threatening unless sarcoma develops.
Okay, that covers Paget's. Now, related to bone structure failing, let's talk about fractures more generally and how bone heals. Fractures are obviously very common.
Extremely common. A fracture is simply a loss of bone integrity due to mechanical injury. Our sources define several types: simple, closed, skin intact; compound, open, bone communicates with skin surface; comminuted, bone broken into multiple fragments; displaced, broken ends are out of alignment; stress fracture, from repetitive submaximal stress; green stick, an incomplete fracture common in the flexible bones of children; and pathologic fracture, occurring through bone weakened by an underlying disease process like a tumor or osteoporosis.
And despite the trauma, bone has this incredible capacity to heal itself.
It really does. Fracture healing is a complex but remarkably efficient biological process involving overlapping stages, orchestrated by gene expression changes and signaling molecules.
What happens immediately after the break?
First, blood vessels rupture, causing bleeding into and around the fracture site. This forms a hematoma, a blood clot. This clot does more than just stop bleeding. It provides a fibrin meshwork that seals the fracture site and acts as a scaffold for incoming inflammatory cells, fibroblasts, and new capillaries, forming granulation tissue.
And signals are released to start the repair.
Yes. Platelets within the clot and the inflammatory cells release a cocktail of growth factors, PDGF, TGFS, FGFs, and others. These factors activate dormant osteoprogenitor cells in the periosteum, the membrane covering the bone, the endosteum, lining the marrow cavity, and surrounding soft tissues, stimulating them to proliferate and differentiate into osteoblasts and chondrocytes. Osteoclasts are also activated to start cleaning up debris.
What happens next? The callus forms.
Right. Initially, a soft tissue callus, or procallus, forms from the granulation tissue. It provides some anchorage, but isn't rigid. Then, typically within the first couple of weeks, the activated osteoprogenitors start laying down woven bone, both under the periosteum and within the marrow cavity. Simultaneously, some mesenchymal cells differentiate into chondrocytes, forming islands of fibrocartilage and hyaline cartilage within the callus, especially in areas with less stability or lower oxygen.
So the callus is a mix of bone and cartilage.
Exactly. This bony callus, a mixture of woven bone and cartilage undergoing endochondral ossification, bridges the fracture gap and provides increasing stability. It usually reaches its maximum size around 2-3 weeks after the fracture. As it progressively mineralizes, it becomes stiffer and stronger, eventually allowing for weight bearing.
And then it gets remodeled back to a more normal shape.
Yes, that's the final longer phase. The initial callus is usually larger than the original bone. Over months to years, the excess callus is gradually resorbed by osteoclasts, and the woven bone is replaced by stronger, organized lamellar bone through the action of BMUs. The medullary cavity is reestablished. This remodeling process reshapes the bone back towards its original form and strength.
Does healing always go perfectly?
In healthy children and young adults, it often results in near-perfect restoration. However, several factors can interfere. Inadequate immobilization is a big one. If the fracture site keeps moving, it can delay healing, delayed union, or prevent it altogether, non-union. A persistent non-union can sometimes lead to the formation of a fluid-filled cystic space lined by synovial-like cells, creating a false joint or pseudoarthrosis.
What else can go wrong?
Infection is a major obstacle, especially in open fractures. Poor nutritional status, underlying systemic diseases, certain medications, and inadequate blood supply to the fracture site can all impair healing. Obviously, pre-existing bone diseases like severe osteoporosis or skeletal dysplasias also complicate matters.
Before we get into infections of bone, the outline briefly mentions osteonecrosis, bone death from lack of blood supply.
Yes, a vascular necrosis, AVN, or osteonecrosis. It's essentially an infarct or tissue death due to ischemia, occurring within bone and marrow.
What causes the blood supply to fail?
Fractures disrupting blood vessels are a common cause, especially in certain locations like the femoral head. Use of corticosteroids is another major culprit, though the exact mechanism isn't perfectly understood. Other associations include excessive alcohol use, bisphosphonate therapy, particularly in the jaw, sickle cell disease, lupus, pancreatitis, pregnancy, radiation therapy, dysparism, the bends, a whole range of things.
Where does it typically happen, and what are the consequences?
It can occur in the medullary cavity of the bone shaft, where it might be clinically silent, or more significantly in the subchondral bone, the area just beneath the articular cartilage. Subchondral osteonecrosis is problematic because the dead bone can collapse under stress.
Leading to joint problems.
Exactly. The collapse disrupts the smooth articular surface, leading to damage of the overlying cartilage and the rapid development of severe secondary osteoarthritis. That's often the major clinical consequence.
Okay, now let's dive into infections in the bone itself. Osteomyelitis.
Osteomyelitis means inflammation of the bone and bone marrow, and in almost all cases, it's caused by an infection. It can be a single localized problem or a complication of a systemic infection.
What kinds of organisms cause it?
Pretty much anything can. Theoretically, viruses, parasites, fungi, bacteria, but by far the most common are pyogenic, pus-forming bacteria, and mycobacteria, like the one that causes tuberculosis. We're also seeing more infections with unusual or opportunistic organisms, especially in immunocompromised patients.
Let's focus on pyogenic osteomyelitis first, bacterial infection. How do bacteria usually get into the bone?
There are three main routes. Hematogenous spread is common, especially in children. Bacteria traveling in the bloodstream, perhaps from a seemingly minor skin infection or even transiently from the gut, can lodge in the small blood vessels of bone, typically in the metaphysis, growing end, of long bones where blood flow is slower.
Okay, bloodstream seeding. What else?
Spread from a contiguous source. This is more common in adults. An infection in a distant soft tissue, like a diabetic foot ulcer, or infection introduced during surgery or from an open fracture, can spread directly into the bone.
And the third route?
Direct implantation, like from a penetrating injury, a deep wound, or even a contaminated injection.
You mentioned Staphylococcus aureus is often the culprit.
Yes, Staph aureus is responsible for the majority of cases, especially hematogenous osteomyelitis. But other bacteria are associated with specific situations. For instance, Pseudomonas or Klebsiella might be seen more in IV drug users or those with genitourinary infections. Haemophilus influenza used to be common in young children before the Hib vaccine. Salmonella is classically associated with osteomyelitis in patients with sickle cell disease, but in about half the cases, no specific organism is identified.
What happens in the bone once the bacteria arrive? What does it look like pathologically?
In acute osteomyelitis, the bacteria proliferate, trigger an intense inflammatory response with lots of neutrophils, and cause necrosis, death, of bone cells and marrow. This can happen within 48 hours. The infection spreads through the Haversian canals within the bone and can reach the periosteal surface.
And in kids, the periosteum lifts off.
Yes, in children, the periosteum is less firmly attached than in adults. Pus collecting underneath can lift it off the bone surface, forming a subperiosteal abscess. This lifting further compromises the blood supply to the underlying cortex, leading to more extensive bone death. The dead piece of bone is called a sequestrum.
What happens if the infection isn't cleared? Chronic osteomyelitis.
Right. If the acute infection persists due to delayed diagnosis, inadequate treatment, extensive necrosis, or weakened host defenses, it can become chronic. This happens in maybe 25% of cases. In chronic osteomyelitis, the body tries to wall off the infection.
How does it do that?
Over time, the initial neutrophil infiltrate is replaced by chronic inflammatory cells, lymphocytes, plasma cells, macrophages. Cytokines released by these cells stimulate ongoing bone resorption, but also trigger reactive bone formation by the surrounding periosteum. This new shell of living bone laid down around the infected area is called the involucrum. It essentially encases the dead sequestrum.
So you have dead bone trapped inside a sheath of new bone.
Exactly. And the infection can smolder within this sequestrum for years, potentially flaring up periodically, often with draining sinuses forming through the involucrum and skin. Chronic osteomyelitis can lead to complications like pathologic fractures, secondary amyloidosis from chronic inflammation, endocarditis, or sepsis.
What about mycobacterial osteomyelitis? That's TB affecting bone.
Yes, caused by Mycobacterium tuberculosis. It tends to be more insidious, more destructive, and harder to treat than typical bacterial osteomyelitis. Its incidence has increased globally with factors like HIV/AIDS and increased migration. Bone involvement occurs in a small percentage, maybe 1–3% of patients with active tuberculosis elsewhere in the body.
How does TB get to the bone?
Usually via hematogenous spread from a focus in the lungs or elsewhere. It can also spread directly from an adjacent infected site like lymph nodes to vertebrae.
Where does it commonly affect?
The spine is the most frequent site, involved in about 40% of cases. This is known as pot disease. The infection typically starts in a vertebral body, then spreads through the intervertebral disc to adjacent vertebrae.
Leading to collapse and deformity?
Yes. The destruction of vertebrae and discs can lead to compression fractures, resulting in spinal deformities like kyphosis, forward curvature or scoliosis, lateral curvature, and potentially compressing the spinal cord, causing neurological deficits. Microscopically, you see the characteristic features of TB granulomatous inflammation with caseous necrosis.
What about skeletal syphilis? Is that still seen?
Much rarer now due to effective antibiotic treatment for syphilis. Bone involvement can occur in both congenital syphilis, acquired before birth, and tertiary, late-stage, acquired syphilis.
What happens in congenital syphilis?
The sparachetes is localized to areas of active bone formation, like the growth plates and periosteum causing inflammation, osteochondritis and periostitis. This can lead to characteristic deformities like the saber shim, where reactive new bone is laid down on the front of the tibia.
And in acquired syphilis?
Bone lesions typically appear in the tertiary stage, years after the initial infection. Common sites include the nose, palate, skull, and long bones like the tibia. Pathologically, you see inflammatory granulation tissue with lots of plasma cells, bone necrosis, and often gummas, the characteristic rubbery lesions of tertiary syphilis.
Okay, we've covered infections. Let's move into the complex world of bone tumors. What are some general principles?
Okay. Bone tumors have certain tendencies. Many arise in specific locations in long bones. Age is often a predictor, for example. Osteosarcoma peaks in adolescence, often near the knee, while chondrosarcoma is more common in older adults, often in the pelvis or proximal limb bones. Benign tumors are more common than malignant ones and are often found incidentally or cause pain or fractures.
Diagnosis relies on imaging and biopsy.
Yes, radiologic imaging, X-rays, CT, MRI, is crucial for determining the location, size, margins, and internal characteristics of the lesion, which often provides strong clues. But definitive diagnosis usually requires a biopsy for histological examination and increasingly molecular diagnostics to look for specific genetic changes. Classification is primarily based on the presumed cell type of origin and the type of matrix the tumor produces, bone, cartilage, etc., or sometimes based on clinical features if the origin is unclear.
What are the most common primary bone cancers, excluding blood cell tumors?
The big three are osteosarcoma, bone-forming, chondrosarcoma, cartilage-forming, and Ewing sarcoma, small round cell tumor.
Let's start with bone-forming tumors. These make osteoid or woven bone. Osteoid osteoma and osteoblastoma sound similar.
They are. Both are benign tumors characterized by the production of woven bone by benign osteoblasts. They share similar histology but differ significantly in size, location, and clinical presentation.
Okay, osteoid osteoma.
This one is small, defined as less than 2 centimeters in diameter. It typically occurs in adolescents and young adults, predominantly males, and often arises in the cortex of long bones like the femur or tibia. The key clinical feature is severe pain, classically worse at night, that is characteristically relieved by aspirin or NSAIDs. This pain is thought to be due to prostaglandins produced by the tumor cells.
And osteoblastoma.
This is larger, greater than 2 centimeters. It has a predilection for the posterior elements, laminae, pedicles of the spine. The pain associated with osteoblastoma is usually dull and achy, and importantly, it's not typically relieved by aspirin. Radiographically, it usually lacks the prominent reactive bone sclerosis seen around an osteoid osteoma.
What do they look like microscopically?
Both consist of haphazardly arranged trabeculae of woven bone rimmed by prominent, active-looking but cytologically benign osteoblasts. The spaces between the trabeculae are filled with loose vascular connective tissue. Differentiating them from a low-grade osteosarcoma relies on the benign appearance of the cells and the well-defined margins. The osteoid osteoma has a characteristic central nidus on imaging, which is the actual tumor surrounded by dense reactive bone.
How are they treated?
Osteoid osteoma, because it's small and well-defined, can often be treated minimally invasively with radiofrequency ablation to destroy the nidus. Osteoblastoma usually requires more traditional surgical removal, like curettage or en bloc excision.
Now, the big one, osteosarcoma, the most common primary malignant bone tumor.
Correct, making up about 20% of primary bone cancers, excluding myeloma. It has a bimodal age distribution. About 75% occur in patients younger than 20, typically during the adolescent growth spurt. There's a smaller second peak in older adults, often arising secondary to other conditions like Paget disease, previous radiation, or bone infarcts.
Most common location.
The metaphyseal region near the growth plate of long bones, especially around the knee distal femur or proximal tibia, accounts for about half of all cases.
Genetics play a big role here. RB and TP53 mutations.
Yes, genetic alterations are central to its pathogenesis. Mutations in the RB tumor suppressor gene are found in a majority of sporadic osteosarcomas. Individuals with inherited germline RB mutations who develop hereditary retinoblastoma have a dramatically increased risk, like 1,000-fold, of developing osteosarcoma later. Similarly, mutations in the TP53 tumor suppressor gene are common in sporadic cases, and individuals with inherited TP53 mutations, Li-Fraumeni syndrome, also have a significantly higher risk. Other common alterations involve genes that regulate the cell cycle, like inactivation of CDKN2A or amplification of MDM2 and CDK4.
What's the absolute defining feature pathologically?
The production of osteoid matrix, or immature woven bone, directly by the malignant tumor cells. That is the hallmark. Seeing malignant, often pleomorphic anaplastic cells with abnormal mitotic figures actually laying down pink, mineralized or unmineralized bone matrix confirms the diagnosis. This matrix can have a delicate lace-like pattern.
So, malignant cells making bone equals osteosarcoma.
Yeah.
How does it behave clinically?
It's a highly aggressive malignancy. It grows destructively, often breaks through the cortex, lifts the periosteum, creating a characteristic radiographic sign called Codman triangle, and forms large soft tissue masses. Crucially, it has a strong propensity to metastasize early, usually hematogenously via the bloodstream to the lungs. Metastases to other bones or the brain can also occur. It's assumed that micrometastases are present at diagnosis, even if not visible.
How has treatment evolved?
The approach now is multimodal. Typically, patients receive neoadjuvant chemotherapy, chemo before surgery, to shrink the tumor and treat micrometastases, followed by surgical resection, often limb-sparing surgery now, and then further adjuvant chemotherapy. This combination has dramatically improved outcomes.
What's the prognosis like now?
With modern therapy, the 5-year survival rate for patients with localized osteosarcoma is around 70%. However, the prognosis remains poor for patients who present with overt metastases, have recurrent disease, or develop osteosarcoma secondary to other conditions, with survival rates often less than 20%. The amount of tumor necrosis seen after neoadjuvant chemotherapy is an important prognostic factor.
Okay. Next category, cartilage-forming tumors. These make hyaline or myxoid cartilage.
Right. Tumors derived from cartilage cells are collectively the most common type of primary bone tumor, but the vast majority are benign. Malignant cartilage tumors, chondrosarcomas, are much less frequent than benign ones.
The most common benign bone tumor overall is the osteochondroma.
Yes, also known as an exostosis. It's not really a true neoplasm, but more of a developmental anomaly, an outgrowth of bone capped by cartilage that arises from the surface of bones formed by endochondral ossification.
Where they typically occur.
Most commonly near the ends, metaphysis, of long tubular bones, especially around the knee, originating near the growth plate. They only develop in bones that have a cartilage precursor phase. About 85% are solitary and sporadic. The rest occur as part of an autosomal dominant syndrome called multiple hereditary exostosis, MHE, which is caused by mutations in the EXT genes.
What do they look and feel like?
They present as slow-growing bony lumps. They might cause pain if they impinge on a nerve or if the stalk fractures. The cartilage cap resembles a disorganized growth plate and undergoes endochondral ossification at its base, forming the bony stalk, which is continuous with the cortex and medullary cavity of the host bone. In MHE, the multiple lesions can interfere with normal bone growth, causing shortening or bowing.
Do they become malignant?
Malignant transformation of a solitary osteochondroma into a chondrosarcoma is very rare, less than 1%. The risk is slightly higher in patients with MHE. Usually, they stop growing once cystallital maturity is reached and are treated by observation or a simple excision if symptomatic.
Okay, what about chondroma? That's a tumor within the bone.
Yes. A chondroma is a benign tumor composed of mature hyaline cartilage arising within the medullary cavity. They are particularly common in the small tubular bones of the hands and feet. Elsewhere, like the femur or humerus, they need to be carefully distinguished from low-grade chondrosarcoma.
How do they present?
Often found incidentally on X-ray, or they can cause pain or pathologic fracture. When multiple chondromas occur, it's called enchondromatosis, Ollier disease. If combined with soft tissue hemangiomas, it's Maffucci syndrome. These syndromes cause more significant deformities and carry an increased risk of other malignancies, including transformation of a chondroma into chondrosarcoma, and are often associated with mutations in the IDH1 or IDH2 genes. Solitary chondromas very rarely undergo malignant change.
What do they look like pathologically?
They appear as well-circumscribed nodules of gray-blue, translucent cartilage, usually less than 3 centimeters. Histologically, it's mature hyaline cartilage with benign-appearing chondrocytes in lacunae. Calcification and bone formation can occur at the periphery. Lesions in Ollier or Maffucci can be more cellular and atypical, making distinction from chondrosarcoma tricky. Treatment is usually observation or curettage.
And the malignant counterpart is chondrosarcoma.
Correct. A malignant tumor whose cells produce cartilage matrix. It's more common in adults, typically over 40, and often arises in the central skeleton, pelvis, shoulder, ribs, rather than the distal extremities.
What drives chondrosarcoma development?
It's genetically diverse. Some arise from pre-existing benign lesions, like in MHE or in chondromatosis, often involving EXT or IDH mutations. Sporadic chondrosarcomas frequently show silencing of the CDKN2A tumor suppressor gene. Other genetic pathways are also implicated depending on the subtype and grade.
What does it look like pathologically? How is it graded?
Grossly, it forms nodules of glistening gray-white cartilage that permeate the marrow cavity, erode the cortex, and often form a soft tissue mass. Histologically, the key is assessing cellularity, nuclear atypia, size, shape, staining, and mitotic activity of the chondrocytes within the cartilage matrix. This forms the basis for grading, usually grade 1, 2, or 3.
And grade is really important for prognosis.
Extremely important. Grade 1 chondrosarcomas are low grade, look relatively bland, grow slowly, and rarely metastasize. 5-year survival is high, maybe 80–90%. Grade 3 chondrosarcomas are high grade, look much more malignant with high cellularity and significant atypia, are aggressive, metastasize frequently, around 70% spread, often to lungs, and have a much lower 5-year survival, maybe around 40–50%. Grade 2 is intermediate.
Are there specific subtypes?
Yes, besides the conventional type, there are subtypes like dedifferentiated chondrosarcoma, a low-grade tumor juxtaposed with a high-grade non-cartilaginous sarcoma. Clear cell chondrosarcoma features large cells with clear cytoplasm, and mesenchymal chondrosarcoma, composed of primitive, small, round cells mixed with islands of cartilage. These often have different behaviors and genetic profiles.
How is chondrosarcoma treated?
For conventional chondrosarcomas, the mainstay is wide surgical excision. They're generally resistant to chemotherapy and radiation. For the more aggressive subtypes like mesenchymal or dedifferentiated, surgery might be combined with chemotherapy due to their higher metastatic potential.
Okay, let's move to tumors of uncertain origin. Ewing sarcoma is a key one here.
Yes, Ewing sarcoma is a malignant tumor composed of primitive, small, round, undifferentiated cells. It's the second most common malignant bone tumor in children and young adults, with about 80% occurring before age 20. There's a striking predilection for Caucasians. It's rare in individuals of African or Asian descent.
Where does it typically arise?
Often in the diaphysis shaft of long tubular bones, like the femur, but also common in flat bones, like the pelvis.
What are the symptoms?
Typically presents as a painful, enlarging mass. The affected area might be tender, warm, and swollen. Systemic symptoms like fever, fatigue, elevated sedimentation rate, ESR, anemia, and leukocytosis are common and can mimic an infection like osteomyelitis.
What does it look like on imaging?
Radiographically, it's usually a destructive gliolytic lesion with poorly defined, permeative, or moth-eaten margins. It often extends into the surrounding soft tissues. A characteristic periosteel reaction is often seen, where layers of reactive new bone form parallel to the shaft, creating an onion skin appearance.
And there's a specific genetic hallmark.
Yes, absolutely. Ewing sarcoma is defined by characteristic chromosomal translocations that create fusion genes. The most common is T1122, Q24, Q12, which fuses the EWS gene on chromosome 22 with the FLI1 gene, a transcription factor, on chromosome 11. Other related fusions involving EWS or similar genes with other transcription factors can also occur. These fusion proteins act as aberrant transcription factors driving the cancer. It's considered a tumor with a relatively simple karyotype.
How is it treated and what's the prognosis?
It's treated aggressively with multi-agent chemotherapy, neoadjuvant and adjuvant, combined with surgical excision and or radiation therapy. The response to chemotherapy, amount of tumor necrosis, is a key prognostic factor. With this combined approach, the 5-year survival rate is now around 75%, and long-term cure rates are about 50%.
Next, giant cell tumor of bone. Sounds like it involves giant cells.
Yes, hence the older name osteoclastoma. It's characterized by the presence of numerous multinucleated osteoclast-type giant cells mixed with mononuclear stromal cells. It's relatively uncommon and typically arises in the epiphysis end of long bones, usually after the growth plates have closed, so mostly in adults in their 20s to 40s.
Is it benign or malignant?
It's considered benign, but it's known for being locally aggressive and having a significant tendency to recur after treatment.
What's the underlying biology? Why so many osteoclasts?
Interestingly, the multinucleated giant cells are not the neoplastic cells, they are reactive osteoclasts. The actual tumor cells are the mononuclear stromal cells, which are thought to be primitive osteoblast precursors. These neoplastic cells express very high levels of RNKL.
Ah, so they're constantly stimulating osteoclast formation.
Exactly. They drive the recruitment and differentiation of osteoclast precursors via RNKL signaling, leading to the abundance of giant cells and the characteristic localized destructive bone resorption seen in these tumors. Recent studies have found specific mutations in histone H3.3 genes in the neoplastic stromal cells. Like Ewing sarcoma, it usually has a simple karyotype.
How is it treated? Does it metastasize?
Treatment is usually surgical curettage, scraping out the tumor, often combined with adjuvants like phenol or cryotherapy to kill remaining cells. Recurrence rates are quite high, maybe 40–60%. Rarely, maybe in up to 4% of cases, giant cell tumors can metastasize, typically to the lungs. These metastases can sometimes behave indolently or even regress spontaneously, but they represent metastatic disease. The RNKL inhibitor denosumab has shown promise as an adjuvant therapy targeting the underlying biology.
Okay, aneurysmal bone cyst, or ABC, sounds vascular.
It does. It's a benign but often rapidly expanding and destructive bone lesion characterized by multiple blood-filled cystic spaces separated by thin fibrous septa containing fibroblasts, inflammatory cells, and giant cells. It can occur at any age but is most common in adolescents. Common sites include the metaphysis of long bones and the posterior elements of the vertebrae.
Is it a true neoplasm?
Yes, it's now considered a true neoplasm. Many ABCs have specific clonal genetic rearrangements involving chromosome 17p13, specifically affecting the USP6 gene. This rearrangement leads to overexpression of USP6, which seems to drive the lesion's growth, possibly via Wnt signaling. It also has a simple karyotype.
What does it look like on X-ray? The soap bubble?
Often described that way. It's typically an eccentric, expansolytic lesion with well-defined but thin margins, sometimes with a thin sclerotic rim like an eggshell. The internal septations can give it that multiloculated or soap bubble appearance. Fluid levels within the cysts might be seen on CT or MRI. However, this appearance isn't entirely specific, as similar features can sometimes be seen in other lesions.
How does it behave?
Locally aggressive and destructive, but benign, doesn't metastasize. Treatment is usually curettage or excision, but recurrence is fairly common, perhaps 10–50%.
Moving to some very common, less concerning fibrous lesions. Fibrous cortical defect and non-ossifying fibroma.
Yes, these are extremely common developmental defects, not true neoplasms. They represent areas where normal bone is replaced by fibrous connective tissue. A fibrous cortical defect is small, usually a 0.5 centimeter, eccentrically located in the cortex, typically in the metaphysis of the distal femur or proximal tibia. They are found in up to 50% of children over 2 years old, often incidentally.
And non-ossifying fibroma is just a bigger version.
Essentially, yes. If these lesions grow larger, typically over 5 to 6 centimeters, they are termed non-ossifying fibromas, NOFs. They have a very characteristic radiographic appearance, a sharply demarcated, often multilobulated radiolucent lesion with a thin sclerotic border.
What's inside them?
Histologically, they are composed of bland-looking fibroblasts, often arranged in a storiform pinwheel pattern, mixed with macrophages, some of which are foamy, lipid-laden, or multinucleated giant cells. Hemosiderin deposition is common. They are clinically innocuous and most regress spontaneously over time. Occasionally, a very large NOF can cause a pathologic fracture.
Okay. Another fibrous lesion, but distinct. Fibrous dysplasia, also developmental.
Yes, fibrous dysplasia is considered a benign, localized developmental arrest of bone formation. All the components of bone are present, fibrous tissue, woven bone, but they fail to differentiate into mature lamellar bone structures. It arises during skeletal development.
How does it manifest? Different patterns?
Yes, it can involve just a single bone, monostotic fibrous dysplasia, multiple bones, polyostotic fibrous dysplasia, or be part of a syndrome like McCune-Albright syndrome, polyostotic FD, cafe au lait skin spots, endocrine abnormalities, or Maza-Brod syndrome, polyostotic FD plus soft tissue myxoma.
What causes it? Another genetic link.
Yes. It's caused by somatic activating mutations in the GNAS gene, which encodes a stimulatory G protein alpha subunit involved in signaling pathways. Because the mutation occurs post-zygotically after fertilization, individuals are mosaic. The mutation is present in only some cell populations, and the extent and location of involvement depend on when and where the mutation occurred during development. It affects skeletal progenitor cells. Like ABC and GCT, it typically has a simple karyotype.
What do the lesions look like?
Radiographically, they are typically intramedullary lesions that can be egolytic, sclerotic, or mixed ground glass appearance, often expanding the bone and causing thinning of the cortex, potentially leading to bowing deformities. Grossly, the tissue is tan white and gritty. Histologically, the hallmark is irregular, curvilinear trabeculae of woven bone, often described as resembling Chinese characters, embedded in a moderately cellular, bland fibroblastic stroma. Crucially, these bony trabeculae typically lack prominent osteoblastic rimming, which helps distinguish it from other fibroosseous lesions. Islands of cartilage can sometimes be seen.
How does it behave clinically?
Monostotic disease usually presents in adolescence, often stops enlarging when growth plates close, and commonly affects ribs, femur, tibia, jawbones, or skull. It's often asymptomatic, but can cause pain, swelling, deformity, or pathologic fracture. Polyostotic disease presents earlier, can continue to progress into adulthood, and often involves the femur, skull, tibia, and pelvis shoulder girdles, potentially leading to severe, crippling deformities and fractures requiring multiple surgeries. Malignant transformation to sarcoma is a rare complication, seen almost exclusively in polyostotic forms. Treatment is usually focused on managing symptoms and complications. Bisphosphonates may help with pain.
Finally, under bone tumors, we have metastatic tumors. These aren't primary bone tumors, but spread to bone.
Correct. And importantly, metastatic tumors are the most common type of malignancy found in the skeleton in adults, far outnumbering primary bone cancers.
How do cancers spread to bone?
Several routes. Direct extension from an adjacent tumor, spread through lymphatic vessels, or, most commonly, hematogenous dissemination, spread through the bloodstream. Intraspinal seeding via the Batson venous plexus is another route, particularly relevant for prostate cancer spreading to the spine.
What cancers commonly metastasize to bone?
Pretty much any cancer can metastasize to bone, but in adults, the vast majority, over 75%, originate from prostate, breast, kidney, lung, and thyroid cancers. In children, common sources include neuroblastoma, Wilms tumor, osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma.
Where in the skeleton do metastases usually land?
They typically affect the axial skeleton, most often the vertebral column, pelvis, ribs, skull, sternum, and the proximal ends of the long bones, femur, humerus. This is likely due to the rich red marrow and abundant blood supply in these areas. Metastases are often multiple, although some cancers like kidney and thyroid can present as a solitary bone metastasis.
And it can look different on imaging. Lytic versus blastic?
Yes. Metastases can cause bone destruction, lytic lesions, stimulate new bone formation, blastic or sclerotic lesions, or be a mixture of both. There are tendencies. Prostate cancer metastases are classically blastic. Kidney, lung, melanoma, and most gastrointestinal cancers tend to cause lytic lesions. Breast cancer commonly causes mixed lytic and blastic lesions.
How do the tumor cells actually cause these changes? Do they directly resorb bone?
Usually not directly. It's a fascinating interplay between the tumor cells and the native bone cells. For cylitic lesions, tumor cells secrete factors like PTHRP, prostaglandins, cytokines that stimulate osteoblasts and stromal cells to upregulate RA&KL. This drives excessive osteoclast activity and bone resorption, which in turn releases growth factors from the matrix that can fuel further tumor growth, a vicious cycle.
And for blastic lesions?
Tumor cells secrete factors like WNT proteins or BMPs that directly stimulate osteoblast proliferation and activity, leading to the deposition of new, often disorganized bone.
What's the prognosis for bone metastases?
Generally, the presence of bone metastases indicates advanced, widespread cancer, and the prognosis is often poor. Treatment goals are typically palliative, managing pain, preventing or stabilizing pathologic fractures, controlling hypercalcemia, and attempting to slow further progression with systemic therapies, chemo, hormonal therapy, targeted agents, localized radiation, and bone-modifying agents like bisphosphonates or denosumab.
Okay, that's a very thorough tour of bone pathology. Let's switch focus now to joints and related soft tissues. Hyaline cartilage is the key player in joints, right?
Absolutely. It's that smooth, white, specialized connective tissue that covers the ends of bones within synovial joints. Its main job is to provide a low-friction surface for movement and to act as a shock absorber, distributing loads across the joint.
What's it made of?
It's mostly water, about 70%. Then about 10% is type 2 collagen, which provides tensile strength. Around 8% is made up of large molecules called proteoglycans, like aggrecan, which track water and give cartilage its resilience and compressive strength. And embedded within this matrix are the cartilage cells, the chondrocytes, which make up only a small percentage of the volume, but are responsible for producing and maintaining the entire matrix.
And it doesn't heal well.
No, unfortunately. It's avascular, no blood vessels, aneural, no nerves, and lymphatic, no lymphatics. Nutrients have to diffuse through the matrix from the synovial fluid. This limited nutrient supply and the low metabolic activity of chondrocytes mean its capacity for repair after injury is very poor.
How does cartilage get damaged in disease?
Primarily through disruption of the balance between matrix synthesis and degradation maintained by the chondrocytes. In diseases like osteoarthritis or inflammatory arthritis, various factors, mechanical stress, inflammatory cytokines like IL-1 and TNF released by chondrocytes themselves or other cells in the joint, can trigger chondrocytes to produce enzymes like matrix metalloproteinases, MMPs, that break down the collagen and proteoglycans. At the same time, the production of inhibitors of these enzymes might decrease, tipping the balance towards destruction.
The most common joint disease by far is osteoarthritis, OA. degenerative wear and tear.
Yes, OA is the most prevalent type of arthritis globally. It's fundamentally a degenerative condition characterized by the progressive loss of articular cartilage. It can be primary, meaning it occurs without an obvious preceding cause, often related to aging and accumulated biomechanical stress. Or it can be secondary, developing as a consequence of some underlying factor like a previous joint injury, obesity, congenital joint deformities, or other diseases.
What are the key risk factors?
Age is the strongest risk factor. Increased biomechanical stress on the joint, often related to obesity or occupational use, is another major factor. There's also a significant genetic component, with variations in genes related to cartilage matrix proteins or signaling pathways influencing susceptibility.
How does the cartilage actually break down in OA? What's the process?
It's thought to start with injury or stress to the chondrocytes. Initially, they might try to compensate, proliferating and increasing synthesis of matrix components. However, degradative processes soon overwhelm synthesis. The composition of proteoglycans changes, making the cartilage less resilient. Chondrocytes release MMPs that degrade the type II collagen network. Cytokines and other inflammatory mediators, even at low levels, contribute to this cycle. Eventually, chondrocytes begin to die off and the matrix breaks down completely.
What changes do you see in an osteoarthritic joint pathologically?
Early on, the cartilage surface loses its smoothness, becoming rough and developing vertical fissures or clefts, fibrillation. It feels softer than normal. As it progresses, chunks of cartilage can detach and float in the joint fluid as loose bodies or joint mice. Eventually, full thickness loss of cartilage occurs, exposing the underlying subchondral bone.
What happens to the bone underneath?
The exposed bone rubs against the opposing bone surface, becoming dense, thickened, and polished smooth like ivory. This is called eburnation. Small fractures can occur in the subchondral bone, allowing synovial fluid to be forced in, forming fluid-filled cavities called subchondral cysts. And at the margins of the joint, bony outgrowths called osteophytes or bone spurs develop. These are capped by fibrocartilage or hyaline cartilage and eventually ossify.
What about the joint lining, the synovium?
In OA, the synovium usually shows only mild inflammation with some congestion, fibrosis, and scattered inflammatory cells. This is a key difference from inflammatory arthritis like RA, where the synovium is the primary site of intense inflammation.
Clinically, what are the classic symptoms of OA?
The main symptom is joint pain, typically described as a deep ache that worsens with activity or weight bearing and is relieved by rest. Stiffness, especially in the morning or after periods of inactivity, is common, but it usually lasts less than 30 minutes. Patients might experience crepitus, a grating or clicking sound or sensation with movement, limited range of motion, and joint enlargement due to osteophytes.
Which joints are most affected?
OA commonly affects weight-bearing joints like the knees and hips, the spine, and specific joints in the hands, particularly the distal interphalangeal DIP joints, causing Heberden's nodes, and proximal interphalangeal PIP joints, Bouchard's nodes. Involvement of the metacarpophalangeal MCP joints or wrists is less typical of primary OA and more suggestive of RA.
Okay, let's contrast that with rheumatoid arthritis, RA. This is systemic and autoimmune.
Yes, RA is fundamentally different. It's a chronic systemic autoimmune disease where the body's immune system mistakenly attacks the joints, primarily the synovium. While joints are the main target, often symmetrically, RA can also affect other organs like the skin, eyes, lungs, heart, and blood vessels.
What drives the autoimmune attack?
It's a complex interplay between genetic susceptibility and environmental triggers. The process is primarily mediated by CD4 plus helper T cells, which orchestrate the immune response, and by autoantibodies produced by B cells plasma cells. These trigger and sustain inflammation within the synovium.
What are the key autoantibodies in RA?
Antibodies against citrullonated peptides, or ACPAs, are highly specific for RA and found in about 70% of patients. Citrullination is a modification of proteins like fibrinogen, collagen, where arginine is converted to citrulline, creating new epitopes that the immune system recognizes as foreign. Rheumatoid factor, RF, which are typically IgM antibodies that bind to the Fc portion of IgG, is also present in about 80% of patients, but it's less specific than ACPA and can be found in other conditions or even healthy individuals. These antibodies contribute to inflammation, possibly by forming immune complexes.
And genetics play a role, HLA association.
Yes, genetics account for about 50% of the risk. Certain HLA-DR alleles, particularly HLA-DR4, are strongly associated with ACPA-positive RA. Environmental factors like smoking and possibly certain infections like periodontal disease are thought to trigger citrullination in susceptible individuals, initiating the autoimmune response.
What does the inflamed synovium look like in RA?
Pathologically, the synovium becomes markedly thickened, edematous, and thrown into folds or finger-like projections. Microscopically, you see hyperplasia, increased cell number, and proliferation of the synovial lining cells. A dense infiltration of inflammatory cells, T cells, B cells, often forming lymphoid follicles, plasma cells, macrophages, and increased vascularity due to new blood vessel formation and angiogenesis. Fibrin often covers the surface.
And this inflamed synovium becomes destructive. The pannus.
Yes. This mass of inflamed, proliferating synovium, inflammatory cells, granulation tissue, and fibroblasts is called a pannus. It grows over the surface of the articular cartilage like a destructive carpet, releasing enzymes and cytokines that erode the cartilage and the underlying bone at the joint margins, causing characteristic periarticular erosions and subchondral cysts visible on X-ray.
What's the end result if it's uncontrolled?
As the cartilage is destroyed, the pannus can eventually bridge the joint space, leading to fibrous adhesion between the bones, fibrous ankylosis. This fibrous tissue can then undergo ossification, resulting in permanent bony fusion, bony ankylosis, and complete loss of joint movement.
RA is systemic. What are the extra-articular manifestations?
Rheumatoid nodules are characteristic, though not always present. These are firm lumps found under the skin, often over pressure points like the elbows or forearms. Microscopically, they show central fibrinoid necrosis surrounded by palisading macrophages and lymphocytes. Severe RA can also involve vasculitis, inflammation of blood vessels, inflammation of the linings of the lungs, pleuritis or heart pericarditis, lung fibrosis, and eye problems like scleritis or uveitis.
Clinically, how does RA typically present? How is it different from OA?
Onset can be insidious, with fatigue, malaise, and generalized aches preceding joint symptoms by weeks or months. Joint involvement is typically polyarticular, multiple joints, symmetrical, and often starts in the small joints of the hands, MCPs, PIPs sparing the DIPs, unlike OA and feet. Morning stiffness is prominent and prolonged, often lasting more than an hour, and tends to improve with activity, unlike OA pain. The course is usually chronic and fluctuating, with progressive joint damage if untreated. Blood tests, ACPA, RF, inflammatory markers like ESCRP, and radiographic findings, erosions, joint space narrowing, osteopenia, help confirm the diagnosis.
And it causes characteristic deformities.
Yes, chronic inflammation affects tendons and ligaments as well, leading to characteristic hand deformities like radial deviation of the wrist, ulnar deviation of the fingers, and flexural hyperextension deformities of the fingers, swan neck and boutonniere deformities.
Treatment has improved significantly. TNF inhibitors.
Dramatically. While older treatments focused on symptom relief, NSAIDs, corticosteroids, the development of disease-modifying anti-rheumatic drugs, DMARDs, like methotrexate, and especially the biologic agents targeting specific inflammatory pathways, most notably TNF inhibitors, has revolutionized RA management. These drugs can slow or even halt disease progression. Other biologics targeting T cells or B cells are also available. Long-term use of biologics does carry risks, like increased susceptibility to infections.
What about juvenile idiopathic arthritis, JIA arthritis in children?
JIA isn't a single disease, but a heterogeneous group of chronic arthritides starting before age 16 and lasting at least 6 weeks. It differs from adult RA in several ways. Oligoarthritis, affecting few joints, is more common. Systemic onset with high fevers and rash occurs. Large joints are frequently involved, and rheumatoid factor is often negative, while ANA, anti-nuclear antibody, positivity is common. Pathogenesis likely involves similar immune pathways, T cells, cytokines like TNF, IL-1, IL-6, and treatments are similar to adult RA, including biologics. Prognosis is variable, but chronic disease and disability can occur.
Then there's the group of seronegative spondyloarthropathies. What ties them together?
This is another diverse group of inflammatory arthritides. Key shared features include absence of rheumatoid factor, hence seronegative, inflammation primarily affecting the entheses, sites where ligaments and tendons attach to bone, rather than just the synovium, frequent involvement of the sacroiliac joints and spine, a strong association with the HLA-B27 gene, and a tendency towards bony proliferation leading to ankylosis, joint fusion.
Ankylosing spondylitis is the prototype.
Yes. As ASR primarily affects the sacroiliac joints and the spine, causing chronic inflammation that leads to progressive fusion of vertebrae, bamboo spine, and sacroiliac joints, resulting in pain and stiffness, typically starting in young men. About 90% are HLA-B27 positive. Reactive arthritis is another member, an arthritis triggered by a preceding infection, often gastrointestinal or genitourinary.
Let's quickly cover joint infections. Suppurative arthritis bacterial infection.
Yes, direct bacterial invasion of the joint space. Causes sudden onset of a single, painful, swollen, hot joint with restricted movement, usually accompanied by fever and elevated inflammatory markers. Risk factors include underlying joint disease, weakened immunity, IV drug use, prompt diagnosis via joint fluid aspiration, looking for pus and bacteria, and treatment with antibiotics are critical to prevent rapid cartilage destruction. Any joint can be affected, but knee, hip, shoulder are common. Gonococcal arthritis often presents this way, particularly in young women. Axial joint infection should raise suspicion of IV drug use.
Viruses can also cause arthritis.
Yes, various viruses like parvovirus B19, rubella, hepatitis B/C can cause transient acute or subacute arthritis, either by direct infection of the joint or via immune reactions triggered by the virus.
And Lyme arthritis, caused by the tick-borne spirochete.
Correct. Borrelia burgdorferi. Arthritis is a characteristic feature of late disseminated Lyme disease, occurring weeks to months after the initial tick bite and rash. It typically presents as migratory episodes of swelling and pain in one or a few large joints, especially the knee. Diagnosis is usually clinical plus serologic testing for antibodies against Borrelia. The synovium shows chronic inflammation, sometimes mimicking RA histologically.
Lastly, for joints, crystal-induced arthritis, gout and pseudogout.
These are inflammatory conditions triggered by the deposition of microscopic crystals within and around joints. Gout is caused by monosodium urate, MSU crystals, while pseudogout, more accurately called calcium pyrophosphate deposition disease, CPPD, is caused by calcium pyrophosphate dihydrate, CPPD crystals. Other crystals, like basic calcium phosphate, can also be involved.
Gout is linked to high uric acid levels.
Yes. Hyperuricemia, high uric acid in the blood, is a prerequisite, although not everyone with hyperuricemia develops gout. When uric acid levels exceed solubility limits, MSU crystals can precipitate in tissues, particularly in joints with lower temperatures or prior damage.
How do the crystals cause inflammation?
The crystals trigger an intense acute inflammatory response. They are phagocytosed by macrophages and neutrophils in the joint, which activates the inflammasome complex, leading to the release of potent inflammatory cytokines like IL-1. This recruits more inflammatory cells, creating a vicious cycle. Complement activation also contributes. This results in the characteristic sudden, excruciatingly painful attack of arthritis, often affecting the big toe first, podagra.
What does gout look like pathologically over time?
Acute attacks show dense neutrophil infiltrates with MSU crystals, needle-shaped, negatively birefringent under polarized light, in the synovial fluid and lining. Chronic gout develops after repeated attacks. Urate crystals deposit on cartilage surfaces and in the synovium, leading to chronic inflammation, synovial proliferation, panisecnus, cartilage destruction, and bone erosions. The pathognomonic lesion is the tophus, a large aggregate of MSU crystals surrounded by chronic inflammatory cells and giant cells, often found in synovium, periarticular tissues, or even soft tissues like the earlobe. Kidney damage, urate nephropathy, can also occur.
And pseudogout, CPPD, similar but different crystals.
Similar concept, different crystal. CPPD crystals, calcium pyrophosphate, are typically rhomboid or rectangular shaped and show weak positive birefringence under polarized light. Deposition usually occurs first within the cartilage matrix itself. It's much more common in older adults, often associated with aging or underlying metabolic conditions like hyperparathyroidism or hemochromatosis. Crystal shedding into the joint space triggers inflammation, often presenting as acute attacks mimicking gout, pseudogout, or sometimes as a chronic arthritis resembling OA or RA. Inflammation is generally milder than in gout.
Okay, we've covered bone, cartilage, and joints extensively. Let's finish with tumors involving joints and soft tissues.
Right. True primary neoplasms arising within joints themselves are rare, usually benign. More common are tumor-like conditions. We'll then touch on soft tissue sarcomas.
Tumor-like conditions.
Yeah.
Ganglion and synovial cysts.
Yes. Ganglion cysts are very common. Small, 1.5 centimeters cystic swellings, typically near a joint capsule or tendon sheath, especially around the wrist. They result from myxoid degeneration of connective tissue and are filled with thick gelatinous fluid, but they lack a true cell lining and don't communicate with the joint space. Synovial cysts, like a Baker cyst behind the knee, are actual herniations of the synovial membrane or enlargements of bursae, often associated with underlying joint disease like OA or RA. They do have a synovial lining and communicate with the joint space.
What about tenosynovial giant cell tumor? Sounds like a giant tumor involving giant cells.
It's a benign neoplasm arising from the synovium of joints, tendon sheaths, or bursae. It comes in two main forms: A localized type, often a discrete nodule on a tendon sheath, common in the hand, and a diffuse type, previously called pigmented villonodular synovitis or PVNS, typically affecting large joints like the knee.
What causes it? Related to the bone giant cell tumor.
Interestingly, yes, there's a similar underlying mechanism. Both types are driven by a specific chromosomal translocation, T12, which creates a fusion gene involving COL6A3 and CSF1, the gene for MCSF, macrophage colony stimulating factor. This leads to overexpression of MCSF by the neoplastic cells, which resemble synoviocytes. MCSF then recruits and stimulates the proliferation of non-neoplastic macrophages and osteoclast-like giant cells, which make up the bulk of the tumor mass.
What do they look like?
Grossly, the tissue is often reddish-brown or orange-yellow due to hemosiderin deposition from bleeding. The diffuse type converts the smooth synovium into a tangled mat of folds, villi, and nodules. The localized type is a well-defined nodule. Microscopically, you see the neoplastic mononuclear cells mixed with abundant macrophages, some foamy, some hemosiderin-laden, and multinucleated giant cells.
How do they behave clinically?
The diffuse type, PVNS, often presents like monoarticular arthritis with pain, locking, and swelling, usually in the knee. It can be locally destructive, eroding into adjacent bone, and has a high recurrence rate after surgery. The localized type typically presents as a slow-growing, painless mass, often on a finger tendon sheath, and is less aggressive with lower recurrence rates. Treatment is primarily surgical excision. MCSF inhibitors are being explored as targeted therapies.
Okay, finally, soft tissue tumors in general. Sarcomas.
Right. These are malignant mesenchymal neoplasms, distinct from epithelial cancers, carcinomas, skeletal tumors, or hematopoietic malignancies. They likely arise from primitive mesenchymal stem cells rather than mature differentiated cells. Classification is based on the presumed line of differentiation: fat, muscle, fibrous tissue, etc., morphology, immunohistochemistry, and increasingly molecular genetics. Grade, degree of differentiation aggressiveness, and stage, size, depth, metastasis are critical for prognosis.
You mentioned genetics are key, with simple versus complex patterns.
Yes, this is a major distinction. About 20% of sarcomas have relatively simple karyotypes, often characterized by specific recurrent chromosomal translocations that create oncogenic fusion genes, like EWS, FLI1 in Ewing sarcoma, or SS18 synovial sarcoma. These fusions often act as driver mutations, are diagnostic markers, and potentially therapeutic targets. These tumors often occur in younger individuals.
And the complex ones.
Most adult sarcomas fall into this category. They have complex aneuploid karyotypes with numerous seemingly random chromosomal gains, losses, and rearrangements. They tend to be histologically more pleomorphic and genetically heterogeneous, often associated with defects in fundamental pathways controlling genomic stability, like those involving RB or TP53.
Let's briefly touch on examples based on lineage, as listed. Adipose tumors, lipoma, and liposarcoma.
Lipoma is extremely common, a benign tumor of mature fat cells, usually subcutaneous, soft, mobile, painless, cured by simple excision. Liposarcoma is the malignant counterpart. Key subtypes include well-differentiated liposarcoma, often low-grade, associated with MDM2 gene amplification, myxoid liposarcoma, intermediate grade, characterized by a specific FUS-DDIT3 fusion gene, abundant myxoid matrix, and pleomorphic liposarcoma, high-grade, aggressive, complex karyotype. Behavior varies greatly by subtype.
Fibrous tumors, nodular fasciitis, and deep fibromatosis, desmoid tumors.
Nodular fasciitis is a benign, rapidly growing but self-limited proliferation of fibroblasts, often mistaken for sarcoma initially. Deep fibromatosis or desmoid tumors are different. They are locally very aggressive and infiltrative masses of fibroblasts that frequently recur after excision but do not metastasize. They can cause significant morbidity by encasing vital structures. They are linked to mutations in the WNT signaling pathway, APC or BACATN genes, sometimes associated with FAP Gardner syndrome.
Skeletal muscle, rhabdomyosarcoma.
A highly malignant sarcoma showing skeletal muscle differentiation. Primarily a tumor of children and adolescents. Major subtypes include embryonal, most common, often in head, neck, or GU tract, include sarcoma botrytis variant, alveolar, often in extremities, associated with PAGEX FOXO1 fusion genes, poor prognosis, and pleomorphic, rare, affects adults, high grade. Treatment involves intensive chemo, surgery, and/or radiation.
Smooth muscle, leiomyoma and leiomyosarcoma.
Leiomyoma is a benign, smooth muscle tumor, extremely common in the uterus, fibroids, but can occur elsewhere. Leiomyosarcoma is the malignant counterpart, typically affecting adults, often in deep soft tissues of extremities or the retroperitoneum, or arising from large blood vessels like the IVC. They are often high-grade with complex karyotypes. Diagnosis relies on histology, showing malignant spindle cells with smooth muscle differentiation confirmed by immunohistochemistry.
Briefly, vascular and nerve sheath.
Hemangiomas are benign vascular tumors. Angiosarcomas are malignant. Schwannomas and neurofibromas are common benign nerve sheath tumors. Neurofibroma is linked to NF1. Malignant peripheral nerve sheath tumor, MPNST, is the aggressive malignant form, often arising in NF1 patients or sporadically.
And finishing with two key uncertain origin examples, synovial sarcoma and UPS.
Synovial sarcoma, despite its name, does not arise from synovium. It's a high-grade sarcoma defined by a specific translocation, TX18, creating an SS18-SSX fusion protein. It often affects adolescents and young adults, typically near large joints of the extremities. Can be monophasic, spindle cells only, or biphasic, spindle cells plus gland-like epithelial structures. Aggressive, treated with surgery and chemo, known to metastasize to lungs and, unusually for sarcomas, regional lymph nodes. Undifferentiated pleomorphic sarcoma, UPS, is essentially a diagnosis of exclusion. It's a high-grade, malignant mesenchymal tumor composed of pleomorphic, highly variable cells that cannot be classified into any specific line of differentiation based on morphology, immunostains, or genetics. It's common in deep soft tissues of extremities in older adults, has a complex karyotype, is aggressive, and has a generally poor prognosis with high metastatic rate.
Wow. Okay, that was an incredibly detailed journey through the pathology of bone, cartilage, joints, and soft tissues. We really went from the fundamental building blocks right through to the complex diseases.
We did. And hopefully, seeing how understanding that foundation, the cells, the matrix development, remodeling, signaling pathways like rank LPG or WNT, really illuminates why things go wrong in conditions like osteoporosis, OI, Paget's disease, or even how tumors manipulate the bone environment.
Absolutely. We saw the spectrum from localized developmental glitches like dysostosis to systemic problems like dysplasias or metabolic bone disease. We covered inflammation driven by autoimmunity in RA, by crystals in gout, and by invaders in osteomyelitis. And we navigated the complex classification and biology of bone and soft tissue tumors.
Highlighting those connections, how a faulty signaling pathway can lead to dwarfism, or how misfolded protein causes brittle bones, or how inflammation, regardless of the trigger, drives tissue destruction through common mediators like cytokines and enzymes.
It really feels like we've gone beyond just listing conditions and delved into the underlying cellular and molecular mechanisms, getting closer to that professional level understanding we aimed for.
That was the goal, to equip you with that deeper knowledge, moving past surface descriptions to the why and how, based on the cellular, molecular, and genetic insights from the sources.
Definitely. And as we wrap up this deep dive, here's a final thought to maybe leave you with, reflecting on everything we've covered. Consider that remarkable capacity for repair we saw in fracture, healing this complex, orchestrated biological response. Yet, existing right alongside that resilience is this profound vulnerability to such a diverse array of devastating conditions, developmental errors, metabolic failure, infections, cancers. What does that inherent tension between resilience and fragility tell us about the delicate, perhaps precarious balance needed to maintain the health of our musculoskeletal system?
A fascinating point to ponder until our next deep dive.